Welcome to Japan session, which is the most sleepy timing of the 2-day sessions. I'd like to introduce my fellow panelists first. I'd like to introduce Mr. Fukuhara. He's a representative director of Heart Valve Voice Japan, a patient advocacy organization. And the second panelist would be Ms. Noriko Murakami. She kindly agreed to join this meeting instead of someone who actually cannot make it this afternoon. So special applause to her, Ms. Noriko Murakami. She is a president of Pulmonary Hypertension Association of Japan, another patient advocate from Japan. Her daughter diagnosed pulmonary hypertension a few decades ago, and she has been an active patient advocate in Japan. And last but not least, I would like to introduce Professor Kuwabara from Jichi Medical University. He is an associate professor at Jichi National University, which is the Jichi Medical University. Also, he is a former officer at the Ministry of Health in Japan. So we have three panelists here, and let me explain a little bit about the situation of cardiovascular disease control, countermeasures in Japan. At the very beginning, Dr. Reddy kindly mentioned that Japan is one of the few countries implemented national action plan. Indeed, Japan has implemented or enacted the national legislation in 2019, enacted the national action plan in Japan, and then national government, and also we have 47 prefectural governments, like provincial governments, 47 prefectural governments are required to have each prefectural the prefectural action plan for cardiovascular disease control. I think which is an amazing achievement of Japanese society that we agree upon to prioritize the cardiovascular countermeasures in Japan. However, the garden looks greener if it's far. Mount Fuji looks beautiful from far away, but it's actually a dangerous volcano. So let's see how the reality looks like. So let me start with asking Mr. Fukuhara, from a patient leader of Japan, focusing on cardiovascular diseases, what is your sort of let's say impression of this achievement of Japanese policy on cardiovascular disease?
Noritake-san, thank you. I'm not a leader, so this is one of the patient and advocacy groups. So すみません、日本語でいいんだった。ごめんなさい。それでですね、私法律って誰が作っているのか実はよく知りませんでした。で、若い頃は誰かが作ってそれを国会の人が議員の人が承認する、ただそれだけのことだと思ってました。ただある時ですね、例えば公害訴訟だとか、薬害エイズだとか、そういう薬害の訴訟の時にですね、患者さんとか当事者の方がですね、前に出てお話になっているというのをテレビのニュースでいっぱい見ました。でその時に思ったのは、こういう人たちが声を上げるっていうことが非常に意味があって力があって人々の心が変わるんだということを、感じました。でその後ですね、だいぶ経ってからあるなんていうんですかね、有名な言葉があるっていうことに気がつきました。多分ここにいる皆さんご存知だったと思いますけども、Nothing about us without us っていう、日本語で言うと私たちのことは私たち抜きで決めないでくださいということだと思うんですけども、この言葉って非常にシンプルだけどなんか力強い言葉だし、私たちの活動を象徴するようなことじゃないかなと思ってます。でそういったことがあって、カーディオバスキュラーの、法律が決まる前、 がんの法律が、2006年ですかね、に成立して、でそれの時にも多分患者の声っていうのが非常に反映されたんだと思うんですね。でそれを一つのいい例として、じゃあ2つ目ということで、カーディオバスキュラーの法律ができた時にも私たちの声が反映させられたと、そんなところがあるんで、非常にいい流れの中で法律ができたんじゃないかなというふうに思っています。以上です。
Thank you very much. For those who do not have the headsets, let me briefly summarize what he says. That he thought that the legislation is happening somewhere else, but actually he observed the bottom-up approach of civil society on pollution activities, pollution activities, side effect victim activities, so that he realized the importance of the power of civil society. And in Japan, indeed, we passed the Cancer Basic National Act in 2006, and that was sort of like an echo for him that to realize that actually the patient's voice can change the legislation, and that will bring the replication of the law from cancer legislation, Cancer National Act to Cardiovascular National Act. This is my comment from now on. I think it's a great point that to mention, Mr. Fukuhara mentioned about the Cancer National Act and National Action Plan. That was passed in 2006. And we, HGPI, Health and Global Policy Institute, we are independent, non-profit, non-partisan healthcare policy think tank based in Tokyo. We advocated not only cardiovascular, but various topics with the mission, which is to achieve citizen-centered healthcare policy. And Cancer Basic Act in 2006 was a huge achievement for patient advocacy in Japan. The national government has been required to have patient representative in the National Cancer Control Consortium. So not only medical doctors, academia, but also patient advocates, patient representatives actually received the 2 seats in the national discussion to decide cancer policy, cancer control policy. And that replicated in cardiovascular disease control, passed in 2018. Back to Mr. Fukuhara's comment about that hope from cancer legislation and 2018 Cardiovascular National Act. What was the contribution from patient society, from patient group?
その時から私たち、いろんなところで、お話をする機会をもらいました。で一つは、議員の人とか、協議会の人たちにですね、提言書を出して、私たちが思っていること、患者として思っていること、それをお伝えして、その政策の中に含めていただきたいということを強く求めました。それとですね、協議会の方は、国の方も都道府県も2つあるんですけれども、両方ともにですね、主にパブリックコメントを求められることがあったので、それは非常に有効な手段だと思ってまして、そこを通じてですね、提言書では言えなかったようなことをまた追加でお話をしたりとかする、そういったことで2つ3ついろんなチャンネルを使って私たちに患者の声を届けるということをやってきました。
Thank you. So his answer is one is he and his organization and some other patient organizations developed the policy proposals from patients' perspective with this momentum of getting the policy right. And also there's an opportunity with this policy framework to put the public comments from societies to national level cardiovascular control measures, and also not only national level but also prefectural level countermeasures. So that was sort of like a momentum that been provided, and also patient advocacy group has been contributing to that momentum. Thank you very much for the thoughtful comments. I would like to ask Professor Kuwabara. Kuwabara-san was Professor Kuwabara was one of the health officers in Department of Health, Ministry of Health and Labor and Welfare in Japan, when the cardiovascular disease control national plan was passed. Also, he was super busy with the COVID-19 countermeasures as well. But from your, it can be personal opinion, individual personal opinion, but when you are in Ministry of Health, what was your sort of like a impression why this movement has getting the public attention in Japan?
Okay, thank you very much. To making the law in Japan, it needs a demand from patients and citizens and policy makers and professionals. Not only professional, but also patients and citizens' opinion is very important to making the law. So I think one main reason for we get Japanese cardiovascular disease law, that is from the patient demand. And the other reason of the making the law is Japanese epidemiology demand. There are three reasons of the epidemiology demand. First is stroke and cardiovascular disease are the leading causes of death in Japan. That is about 22% of the total number of deaths in Japan in 2021. And the second reason is about the need for long-term care, especially stroke patients. They need long-term care for their disability. And in Japan, cardiovascular disease, including stroke, are the leading cause of the needs for long-term care in Japan. And that's account for more than 1/5 of the total. And the third reason is about the expense. For the total medical care expenditure, stroke and cardiovascular disease is the highest cost, expensivest cost by injury and classification. And these circumstances have helped to push legislation against stroke and cardiovascular disease. Thank you.
Thank you very much. That's a very comprehensive explanation, and especially the last part. It's Japan is the aging nation in the world, and that super aging society requires better cardiovascular countermeasures. And you are not the foreign situation of that. China rapidly aging, Singapore, South Korea, Thailand, Vietnam. We will face all super aging society in very near future. So I think that's another reason Professor Kuwabara kindly mentioned that countermeasures for cardiovascular disease, the importance from aging population perspective. Thank you very much for that. I'd like to ask Ms. Murakami, from as a patient advocate for decades in Japan, what was your impression about this cardiovascular national action plan?
Please excuse my Japanese. I'm going to speak in Japanese. 実は皆様がおっしゃっていたような循環器対策基本法ということに関してが、それがこの法律が成立しているということに関しては、私たちは大変人数も少なくて小さな患者会なんですけれども、つい1ヶ月ほど前に初めて知りました。で、この法律ができた背景というのもつい最近耳にしました。 ですけれども、この法律がですねできて、私たちのような希少難病の小さい患者会にも恩恵があるらしいということが分かりましたんで、協力してぜひいい形に施行してできたらいいと思っております。
That's a very honest, blunt comments. I really appreciate that. So basically, she didn't know about the National Action Plan. Even she was one of the leading patient advocates in Japan. So I think that's a reality. It's bottom up, but we try to be bottom up, but still, some policies are quite top down. In 2006, in cancer policy, Cancer National Action Plan was passed in Japanese diet. It was quite bottom up from patient advocacy, sort of pressures to policymakers. But since cardiovascular disease control passed in 2018 was a replication of that movement. Okay, let's try to be next cancer, cardiovascular would be. So that replication process was rather, from my personal opinion, that was also kind of top-down atmosphere in Japan. So I think the next step for cardiovascular disease control society like here is how this can be more egalitarian, how this can be more civil society oriented, not doctors only, but patients as well. Murakami-san, one more question is, so you didn't know about the policy, but what's your expectation? What really matters to patients?
ですね、私たち患者はですね、治療をですね、最先端っていうんですか、一番いい治療をですね、日本全国の患者さんが受けられるようにというのが希望しているんですけれども、それは個々の患者団体の方たちが努力いたしまして、薬の導入とか、日本は国民介護保険がありますので、恩恵を受けられると思うんですけれども、じゃあ治療を受けた後の患者さんたちが、自立していくために就労あるいは就学ということに元の病気が発症する前に比べてですね戻っているかといいますと、実は私たちの患者会でもアンケートを最近取ってみたんですけれども、治療を受けて本当は発症した時よりも元気になっているはずの患者さんたちがですね、就労あるいは就学というのが半分以下に落ちているということが分かりました。ですからそれはどういう原因か分かりません。社会的な背景の差別というんですかね、そういうものがあるのか、あるいは患者自身が病気であるから自分は自立して就職したり就学したりしてですね、普通の社会で普通に病気を持ちながら社会的な責任を果たしながら生きていこうとする、そういう意欲に精神的な意味で欠けてるのか分かりませんけれども、患者の QOL というのをですね上げていく、そんなようなことにこの法律がですね役に立っていけば大変嬉しいなと思ってます。
Thank you very much. Just to very briefly summarize that, she emphasized the importance of perspective from quality of life of patients, not only just medication or healthcare provisions, which has been covered in Japan by universal health coverage, but the lives, each day, everyday life of patients, going to school, going to work, even those who he or she has diseases. So that really matters. I think it's a very important takeaways that it's not something medical doctors or primary care doctors see everything, but patient advocates actually can emphasize. It's not just the healthcare provisions, healthcare system, but how the quality of life can be improved. And the law enforcement legal framework can be a help. Thank you for that comment. I'd like to ask Professor Kuwabara. So you mentioned about the 3 reasons of the sort of momentum Japan has been experiencing with the cardiovascular disease controls, but what's the next step for Japan? Like, for example, heart failures in Japan is really getting increased. What's the reason behind, and what's the next step? Is that prevention, better tertiary care, primary care? What's your personal opinion on that?
Oh, thank you very much. The number of stroke is decreasing in Japan, but the number of cardiovascular disease, especially heart failure, is increasing. The reason, one of the reasons for the increase in heart failure is improvement of treatment for ischemic heart failure, such as myocardial infarction for using PCI, and valvular disease using TAVI or mitral clip. And these improvement for treatment of cardiovascular disease treat patients at that time. But after that, the patient did not this, and they can recover, but they become rehospitalization by heart failure, because heart failure is caused by many diseases, ischemic heart disease and valvular disease. That is one of the reasons of the increased heart failure and cardiovascular disease. So I think the most important thing is to prevention for this disease, not only primary prevention, but also secondary prevention for the patient with cardiovascular disease. Thank you.
Thank you. Secondary prevention, I think it's a critical perspective, again, with the aging society and with the comorbidity that patients often have cardiovascular disease and dementia, cancer, and that's a critical point. Thank you very much. And also thank you very much for explaining the reality of heart failure in Japan, the increase of heart failure in Japan. I would like to ask both Mr. Fukuhara and Ms. Murakami-san, about this situation with aging society in Japan. What is the expected role of patient advocacy groups? What patient organization can do more for Japanese society and beyond, for globally? Can I ask Fukuhara-san first?
ペーシェントジャーニーを考えると、まずその認知があって発見があって診断があってで治療があって、あとその治療後のフォローアップ、あとそれ特にはその心不全のようなところはその生涯にわたるフォローアップが必要になってくるわけですね。で私たち患者会としてはやっぱりそのピアサポートというか、そこに力を入れたいというふうに思っています。で私たちが、ある調査をしたところによると、弁膜症だと診断された人に聞いたんですね。でその人たちが弁膜症と診断される前にあなたは弁膜症ということを知ってましたかと言ったら 50% の人は何も知らなかったと、そういう反応なんですね。であと残りの 50% は弁膜症っていう名前は知ってたけどどんな病気かは分からないと、とにかく名前だけ知ってると。これが実際なんです。まだ日本の状態です。でそういったことなんで、認知を早めるということを私たちの中からも、ピアサポートとして力強くそれを推進していきたいというのが1つ目で、2つ目はじゃあ診断されてあなたじゃあ次の専門医のところに行きましたかという質問もしました。そしたらかなりの人はやっぱり行かないんですね。で仕事が忙しいとかそんな大した病気じゃなかったと思ったとか、 いろんな理由で行かない人が多いと。で私たちはやっぱりさっきの言ったように認知されて診断されてっていうところをやっぱり力強くフォローアップとかをしていきたいんで、そういうふうに聞いたら次は何をしないといけないかということを患者さんというか当事者の人たちに話をして、必ず専門医のところに行って大した病気じゃないのか、本当に大した病気なのか、すぐに治療が必要なのかということを話してもらいたいと、そういったピアサポートをやっていきたいというふうに思っています。
Thank you. Thank you very much. I think it's interesting phenomena that patient advocacy groups now focusing on public awareness and peer support, because what I observed in Japan is they started to have peer support, public awareness campaigns, and then they became like a policy advocacy organizations to impact policy. But after changing the policy framework, they realized the importance of peer support and public awareness. I think it's a good circle that we are embracing. And also, I think it's, as Japan has universal health coverage with national health insurance, but still access matters. I think it's a great point as well that it's not about provision of healthcare, but the proactive willingness to go into consultations. And that is something, behavioral change, that patient advocacy can actually collaborate with citizens and civil societies. Thank you for that. Can I ask Ms. Murakami for the same question?
ですね、私たちの希少難病はですね、多分予防というのが大変難しい病気なんですね。ただし早期発見というのは大変重要な課題でありまして、そのためには社会への疾患啓発をまず大変重要視しています。その上でこのような循環器病基本法律というのがですね、施行されるように、そしてすべての循環器病の患者に恩恵を受けられるようにですね、疾患を超えた循環器病患者の会の連携を強めて、声を一つにして、もちろん患者会だけではあまり意味がないので、先生方、アカデミアの先生方とかですね、ステークホルダーの企業その他の方たちと力を合わせてですね、一つのプラットフォームにを作っていただいてですね、そしてこの法律をですね、一日も早く日本で、実際に、実のあるものにしていけたらなと考えております。それからですね、このような会議に初めて参加させていただいたんですけれども、グローバルな感じのグローバルな場での皆様の奨励っていうんですかね、プラクティスをですね参考にさせていただいて、日本で取り入れられるものはぜひ参考にさせていただきたいと思います。以上です。
Thank you. Two things that she mentioned. One is the cross disease within the cardiovascular disease, cross disease collaborations among patient organizations. I think it's something we need an umbrella organization in Japan as well. In cancer, we have a national umbrella organization for patient groups, but not in cardiovascular disease yet. So perhaps we need an umbrella organization to prioritize cardiovascular per se, not each symptoms or diseases. I think that's a very fair point. And also the importance of global collaboration. And thank you very much for this opportunity under Access Health's initiative. So this is one of the opportunities for Japan as well, and learning from best practices around the world. I would like to ask the question to actually Mr. Fukuhara about your expectation about global collaborations in cardiovascular arena.
私たちは、あそこにジョン・ニールいらっしゃいますけれども、グローバルハートハブと一緒に、活動している団体の一つです。彼らと一緒にやることによって、やっぱり私たち日本だけでは考えられないことも、学ぶことも多いですし、特に さっき言いましたペーシェントジャーニーのこととか、シェアードディシジョンメイキングだとか、非常にキーになる言葉っていうのがあると思うんですね。でそれをですね、私たちだけではできないんで、グローバルハートハブの人たちと一緒にですね、今日ここにいらっしゃる皆さんと一緒にですね、進めていきたいと。で私たちの声を、その現場に届けていきたいということを、やっていきたいというふうに思っています。それとあと今朝の話でも連携とかコラボレーションという話がありましたけれども、言葉で言うと非常に耳障りのいい言葉なんですけども、じゃあ実際どうやってやるんですかということになると非常に難しいところがあって、私たちいろんな患者会ともやってますけども、その中でもやはり手を取ってっていうところになかなかいかないというところが日本の中でもあります。ですのでそういったところをどうやったら進められるかというのを自分たちの経験だけじゃなくて、ここにいらっしゃる皆さんの知見とか、経験を教えていただいて、なんとかそこのところにたどり着きたいというふうに思っています。最後のポイントなんですけども、私もそうですし、私たちの団体もそうですけども、みんな小さな、団体なんですね。となってくると、そこで働ける人とか代表になるような人ってなかなか、それだけの知識だとか経験とかって持ってないんで、ぜひともですね、そういう団体に対していろんなサポートをしていただきたいと。でグローバルハートハブの方からもいろんなサポートしてもらってますし、私は日本の循環器の団体とか協議会の方とか、そういう社会からもサポートしていただきたいと。でどんなサポートが必要かって言ったら、例えば私たちやっぱり普通の今まで市民だったのがある時患者になるわけですから、やっぱり医療のこととかってやっぱりわからないんですね。あと社会システムだとか社会保障のことでもやっぱり知らないことがいっぱいあるんですね。でそんな人たちが協議会に行って偉い先生方と一緒に話をするとか、そのポリシーメーカーの人みたいにそこを専門でやってきたような人たちと一緒に話をしないといけないという、これなかなか声を上げたりということもできないということをよく聞いてますので、そんなことができるようなサポートをぜひともみんなで考えていっていただければというふうに思っています。以上です。
Thank you very much. Just to very, very briefly summarize that partnership, collaboration, it's easy to say, but reality, it's tough to actually do that, and I fully agree with that. Scattered organizations, small organizations, and how we can collaborate together with different civil society leaders with different missions, how we can have umbrella. I think that's a very challenging comment, and indeed this kind of like global network is something we can learn from and share best practices, and not only best practices but also lessons. I would like to ask Dr. Kuwabara for your expectation about the global collaboration.
Thank you. One person can do only a few things, but when many people gather and making a group, the group can do many things, and collaborating and connecting each organization is the most important globally. Like this Asian Pacific Heart Summit, I think this is a great opportunity to share the opinion and making a new opinion among all members, including policymakers, professionals, patients, and many students in the world. I think this is the most important thing to improve cardiovascular disease prevention and making policy and save patients in the world. So I sincerely appreciate this opportunity. Thank you.
It's a beautiful comment. Thank you so much, Dr. Kuwabara. To conclude my our session, I'd like to mention one thing, which is the cultural difference of Japan and Asia Pacific. Between Asia Pacific and perhaps Anglo-Saxon countries. Let's say my background is medical anthropology, and I don't want to be culturally incorrect, but if you see the patient advocacy movements or collaboration with the government, with civil society, there is a difference between American way and Japanese way and Thai way. It should be different. We say civil society, bottom up, but the actual implementation, the methodology cannot be replicated because the cultural context is so different. And from anthropological perspective, I think it's really a virtue to have these Asia-Pacific regions can work together, not to end up with a paternalistic way, but with more egalitarian way to collaborate together among our nations, and of course including Australia. Thank you very much, and I will open to the floors for the questions. Thank you.
Thank you for a very informative panel. One of the questions that I have, I'm Mickey from Roche Diagnostics. I need to introduce myself first. So you brought up a very important point, cultural differences, right? So, I guess, Mr. Ryoji, you mentioned earlier that US and the Western culture is different, and then our culture is different. What are the major differences that you see that is so distinct that we really need to take that into consideration? And maybe some of the cultural differences that we experience in Asia could be quite similar. There may be some differences, but maybe there will be similarities as well. Thank you.
I think the question is to me, but I think anyone can answer from this panel. Would you like to go first?
Yeah, I think the most difference is lifestyle between Asian country and US or European countries. For example, when we have food, the food is different. When I go US 8 years ago, there are a lot of hamburgers and fast foods, but that is delicious. I like that. And after I stay and follow their lifestyle, my body weight gained 10 kilograms, only for 6 months. So, in addition, in US, car driving is common, but in Asian place, many people walk a lot. In Tokyo, there are a lot of subway, but when we have a car, that costs very expensive, and it's easy to go many places by subway or train. So that make us walk a lot. So lifestyle is the most different, I think. So we have to take care of this difference and make the good measures for cardiovascular disease for each country. I think that is very important. Thank you.
Very practical perspective, but that actually has some implication that integration of the nutrition policy can be different between Asia Pacific and United States. That's one takeaway. Mike, go ahead, please. Madam. どうぞ。
ですね、今先生がおっしゃったことなんですけれども、これはアメリカとアジアの違いとかアメリカと日本の違いとかじゃなくて、各国の 保険制度の違いは医療に関しては大変大きいかなと考えております。日本の場合は国民皆保険で一応治療薬等をですね、プルーブ承認を取りますと、すべての日本に住む日本人というのはどこにいてもどこに住んでも一律の治療が受けられるようになっております。先ほど知ったんですけど、タイも同じような保険制度だと思います。アメリカは違います。ヨーロッパも国によって、EU っていうのはあるんですけれども、国によって違うと思います。アジアの国々もやっぱりそれぞれの国によって保険制度というのは違うと思いますので、その辺がですね、ちょっとそれぞれの違いというのがありましてですね、でもお互いに学び合うことは学んで、そして、その取り入れられるものは取り入れて自分の国の制度に落とし込んでいくという、これが大切じゃないかなと試験ですけれども感じております。
Thank you. Thank you. My comment to that question is, I think the process of decision-making process is different. In Asia-Pacific regions, mainly the careful consensus building is appreciated, embraced with the harmony of society, and it often can be paternalistic. So we have to be very careful about that. But how we can make a consensus with careful agreements each other, I think that detail, so detailing about that process, I think in Asia it's more sensitive. That's my comment. どうぞ。
私の方から患者会とかに関係して言うとですね、私は一番違うっていうのは、寄付文化が日本ではそれほど発達してないということだと思います。私たちもそうですし、他の患者会もそうですけども、なかなかその必要な資金が寄付で集まらないということになって、そのために活動が制限されたりとかっていうことがあって、もっとその寄付文化が広がればいいかなというふうに思っています。それとあともう一つはボランティアに関することです。なんか日本語でボランティアって言ったら無償のボランティアのことを皆さん思われるんですけども、実際有償のボランティアっていうのもあると思うんですね。でそういったことであなたはボランティアだからただ働きすればいいとか、自分で好きなことをやってるんだから、そのままでいいでしょうということをよく聞くんですけども、やはりそれでは長続きしないんで、ぜひとも寄付文化とボランティア文化というのがもう少し変わればいいかなというふうに思っています。
Very, very fair point. Thank you. Yes, sir. Sorry. Go ahead. I'm sorry. There's a lady beforehand. Sorry about that. Yes, please.
I'm Anita from Indonesia. I'm a patient advocate. I grew up elderly with type 1 diabetes since I was a kid, and later on with diabetes cardiomyopathy. I do agree on the cross-disease collaboration. Is there any reference or example that we can look up into in terms of the collaboration between the cross-disease organizations? Thank you.
So what's is that the question?
Do you have an example of reference that we can look up into in terms of the collaboration between organizations?
Jichi.
私たち日本循環器協会っていうところの会員なんですけども、そこに循環器の患者会が9団体今あります。でどの団体も小さいんですけれども、でその団体を今一緒になって何かできることはないか、何が今できるかって決まってるわけじゃないですけども、今スタートしたばっかりなので、といったことで自分たちだけではそんなこと思いもつかなかったんですけど、日本循環器協会っていう団体ができたことによって、そこの協会が患者会をまとめて、一緒に何かやっていこうということをおっしゃる方が増えたんで、それによって世の中というか私たちの活動も今少しずつ変わりつつあります。でこの先何が待ってるかはちょっと今言えませんけれども、はい。
That's a very fair point. Let me just add it a little bit. So this is a collaboration among medical providers, academic societies, and patient organizations together. Not just patient organizations, but academic societies, patient groups under the one same umbrella in Japan Circulation Association. So I think that's back to the first question. It's kind of harmonized way of patient advocacy in one of the role models, can be role models. And sorry, sir, you have a question, right? And I think it's about time, right, to wrap up.
Thank you. Hi, my name is Manveer Victor. I'm a chairman for Patient Safety in Malaysia, WHO-trained patient advocate. So I've got a question. First of all, congratulations. You all have a fantastic system there in Japan. You're transparent enough to talk about it. So my question is, if you could better the system, what would you import? Ideas, services, what would you import to Japan to better that system? And what would you export? What is that one or two things that you would share with every one of us that will improve our systems as well? Thank you.
In Japan, there is a national plan based on national law for cardiovascular disease. And we published that brief summary in Circulation 4 years ago. And that contained what should we do for prevent cardiovascular disease. And please read that article and please enhance and broaden that context in the world. I think that is one method to we contribute to cardiovascular care. Thank you very much.
Well, thank you. I think we are about time, and we are being known as being punctual. That's one thing we can export, actually. But thank you very much for the attention. And I'm sorry, there are some hands raised, but I could not answer. We could not answer everything. But we have a networking dinner and etc. So thank you very much for this opportunity, Dr. Reddy and Access Health Team, Dimple, and everyone. Thank you. Kopuna Cup.
Thank you very much.